Country SA PHN would like to acknowledge the traditional custodians of the lands across Australia and pay respects to the elders, past, present and future. We recognise and respect the unique cultural and spiritual relationship to the land, waters and seas, which continue to be important to Aboriginal and Torres Strait Islander people living today. Country SA PHN extends a warm welcome to everyone joining us today for this Triage in General Practice webinar. The current shortage of GPs in regional areas and related staff turnover in general practice means longer wait times for appointments. This puts more pressure on administration staff to prioritise the order in which patients are seen, know when to re-perform triage if the patient's symptoms worsen, and when to refer to doctors and nurses for clinical decision-making. A structured and consistent system of triage that is aligned with the current RACGP standards also helps the practice meet accreditation requirements. Non-clinical reception staff are the first point of contact for patients phoning the practice for an appointment. Clearly defined roles and responsibilities within a whole-of-team approach ensures safe and effective triage in determining who needs immediate care, who receives an appointment that day, and who can wait for an appointment for up to 24 hours. Participants will explore the critical role that reception staff play in ensuring the right patients are seen at the right times. We will also cover the importance of timely communication and documentation throughout the triage process in reducing medico-legal risk for reception staff performing triage. So what is triage and why is it important in general practice? The process of triage was first described in a manual of French military medical care in 1792, when the French word trier, meaning to separate, sort, shift or select, was applied by a French surgeon in the Napoleonic Wars. The wounded were sorted according to the severity of their injuries into dangerously wounded, less dangerously wounded, and slightly wounded. Injured soldiers were treated regardless of their rank or nationality, according to the urgency of care required. By the early 1900s, triage had evolved from the battlefields to emergency departments throughout the Western world. Although triage is now accepted within general practice, the variable ability of resources, particularly in rural areas, means there is often a mismatch between what is required and the timeliness of care provided. Triage in general practice is a way of sorting patients who phone the practice or present for care to ensure that patients with the greatest clinical need are prioritised for treatment. It is important to know what constitutes triage, i.e. a triage policy and procedures and triage tools, and to retain this as evidence for accreditation purposes. So what is the purpose of triage? Triage helps practices meet patient safety requirements by ensuring that the sickest patients are seen first. It provides a structured and consistent approach to seeing patients. It alerts the practice team to potential emergencies, and if the patient phones ahead, allows time for resource allocation and contingency planning. The current pandemic has put a spotlight on triage and the way calls and presentations are screened by reception staff to ensure the safety of staff and other patients attending the practice. Knowing the patient may have a communicable disease allows the practice to allocate a staff member to triage the patient in their vehicle, provide the patient with a mask, and escort them to an isolated room at the practice for medical review. Having a triage policy in place is also important for risk management and helps the practice meet accreditation requirements. Defined roles and responsibilities for practice staff and clearly articulated triage processes take the guesswork out of prioritising treatment. Any evidence of triage needs to be retained by the practice for accreditation purposes. Core principles of triage include Consistent guidelines to assist in prioritising the order in which patients are seen, a well thought out decision support system to elicit the required response from reception staff, key assessment questions which assist in categorising the problem according to the urgency, a robust triage system allowing staff to quickly identify and respond to emergencies. This could mean transferring the call to clinical staff immediately or asking the patient to hang up and dial 000. Appropriate documentation of triage outcomes may be useful for tracking and responding to changes in the patient's condition, managing risk, and meeting accreditation requirements. Although there was no findings against Heiss in the Alexander versus Heiss matter in 2001, the failure to access readily available triage training and document conversations taking place between patients and reception staff on an approved patient contact form in the current environment may reflect poorly on both the practice and the staff member. A responsive triage system ensures timely access to care. It is everyone's business to keep patients safe by becoming familiar with current RACGP standards around triage, triage policy and procedural guidelines at your practice for administrative and clinical staff, customised triage guidelines, e.g. pop guns, and where they can be easily located, and a system for documenting triage responses. So what can your practice do to involve every member of the practice team? Combine training for clinical staff and reception staff, e.g. triage training and CPR training, managing difficult people, and aggression training, displaying the triage tool in reception area, displaying signs in the reception area with information about time-critical emergencies, advising patients in the waiting room to let reception staff know if they have a serious medical condition or are experiencing major symptoms. Triage policy with input agreement from all members of the practice team. Information about telephone triage on the practice's internet. And icebreakers to get people used to working as a team. To meet current RACGP standards for patient triage, all members of the practice team must know how the practice identifies patients with an urgent medical need, how it identifies medical emergencies and reprioritises appointments accordingly, how the practice seeks urgent medical assistance from a clinical team member, and how it deals with patients who have urgent medical needs when the practice is fully booked. Either in-house or external training may be required to enable administrative and clinical staff to identify patients in need of urgent care. Administration staff who access patient health records to inform the clinical team of triage responses must also know how to comply with patient confidentiality requirements. So where does triage take place? Reception staff effectively undertake telephone triage whenever a patient finds the practice to book an appointment with a doctor or nurse. Before putting the call on hold, it is important to ask whether the matter is urgent and know which calls to transfer to clinical staff. Telephone triage is also an important way to manage cross-infection by identifying infection risk before the patient presents and taking steps to reduce exposure to other patients and staff. Patient presenting at reception with or without an appointment may also require triage. It is not uncommon for patients to require triage following collapse in the waiting room, in practice hallways, and even in the patient toilet. Some patients may feel well enough to drive themselves to the practice, but may collapse in the car park or surrounding areas. Patients may also require triage after their consultation. This includes people under a nurse's supervision who faint after having blood taken or who have an adverse reaction following immunisation. Evidence of triage for accreditation purposes extends to on-hold and after-hours messages when the patients phone the practice, the standard message being, if this is an emergency, hang up and call 000 immediately. Other evidence of triage could include triage guidelines at the reception area, triage flowcharts available for reception staff members and the clinical team, signage displayed in the waiting area advising patients with a high-risk condition or deteriorating symptoms to let reception staff know, and evidence that the waiting list is updated if there is an emergency and that patients in the waiting room and those yet to attend the practice are informed that this may increase their waiting time. Scheduling care is an important part of the triage process. An efficient appointment system allows for 1/3 of the appointments to be scheduled on the day, with 2/3 of appointment times allocated to advance bookings. This helps to ensure that booked appointments run on time, allows the practice to accommodate urgent bookings and longer appointments as required throughout the day. An SMS reminder system also reduces the number of no-shows. Avoid booking appointments too far ahead, as this clogs up the booking system. Appointments are more likely to be forgotten. The original problem may have evolved, requiring an earlier appointment, or the problem is no longer of concern to the patient. Triage does not end when the patient's problem has been categorised upon arrival at the practice. It involves updating clinical staff on any changes in the patient's condition while waiting to see the doctor, and keeping a close eye on frail or vulnerable people in the waiting room. If there is an emergency, it is both courteous and in line with RACGP standards to provide an update on new waiting times to the patients in the waiting room and to advise patients who are yet to arrive that their appointment time has been delayed. It is necessary to ask patients calling the practice whether their problem is urgent before putting them on hold. If urgent, advise the caller to hang up and call 000 immediately. If reception staff are unable to determine the urgency of the problem, the call should be transferred to a GP or nurse. The practice's triage policy and procedures need to support non-clinical staff who are uncertain about patient triage to interrupt the nurse or GP to perform triage. We have already established that we need to ask the caller if the matter is urgent before putting them on hold. It is also important to end emergency calls with a disclaimer such as, "Call back if you get worse." Check your on-hold message to make sure patients aren't waiting too long to hear this instruction. After-hours messages recorded by practices typically advise advice to call 000 if it is an emergency and provide contact details for the locum service. After-hours services such as Health Direct are a well-used and widely accepted after-hours primary care service in Australia and New Zealand, and the Health Direct number may be included in the after-hours message. The literature suggests that more understanding is needed about how telenursing services like Direct Health may be integrated into general practice settings. Reception staff need to understand their non-clinical role in patient triage and that it involves asking screening questions framed in the context of the patient's presenting systems and described in the patient's own words. The role of reception staff is to guide the patient towards a set of actions aimed at delivering optimal care, but stopping short of clinical diagnosis and treatment. The purpose of retrieving the patient file is, for reception staff, to file the non-clinical triage activity in the patient's record and possibly send information to the emergency department as requested by clinical staff. Reception staff need to become familiar with types of calls that require transfer to clinical staff and when to interrupt the GP or nurse. When the emergency call has ended, it is important to retrieve the patient file and document the activity in the patient record. Unless the patient is incapacitated, it is preferable that they, or the person with them, calls 000 if an ambulance is required. This allows the operator to give the patient specific instructions while waiting for the ambulance to arrive, provides paramedics with an update on the patient's condition firsthand, and enables more precise directions, particularly if the location is difficult to access. If there is no other option, call 000 on the patient's behalf, e.g. if alone and deteriorating, limited English, or mobile is nearly flat. You may have already confirmed the patient's full name, address and date of birth, retrieved the patient history and contacted clinical staff if indicated. Ask the patient for the address that they are currently at and whether it is a house, building or street. If difficult to access, obvious landmarks would be helpful. Then ask the patient for the best number to contact them and advise them to leave this line free for paramedics to make contact. Finally, advise the patient to unlock the front door, leave the light on and secure any animals. If possible, ask whether they would like their next of kin to be notified. Ambulance costs are not covered by Medicare, and an ambulance subscription is recommended, as the cost of transport on an emergency call-out starts at $1,044. Holders of a healthcare card, pension card, or Department of Veteran Affairs card can inquire about what they are covered for by ringing the toll-free number, by sending an email to SA Health, or by visiting the SA Ambulance Service website. Patients with private health cover need to check with their insurance provider to find out their premium covers ambulance transport, and if so, their level of cover. Either are you covered only for emergency ambulance services, or does your cover include non-emergency transportation, such as for tests, ongoing treatment, or transfer to another hospital? All requests for ambulance transport are directed to the SAAS Emergency Operations Centre in Adelaide using either 000 for urgent ambulance attendance or 1300 881 700 for non-urgent ambulance bookings. Patients sometimes die in waiting rooms while waiting for care to be provided. The practice could display signage in the waiting room advising patients with a high-risk condition or deteriorating symptoms to let reception staff know. It is important to periodically check the condition of patients and provide regular updates on waiting times. There are 6 main steps in the triage process, named the prioritisation of patients, a guide to urgency for non-clinical staff, commonly known as popguns. Step 1. Ask screening questions. Is this urgent, or can I put you on hold? Then, to give the most suitable appointment, is it okay to ask you a few questions? Step 2. Prioritise according to the urgency of medical need. For example, Category A for chest pain compared to Category F for an eye or ear infection. Step 3. Provide patient management advice, e.g. if this is an emergency, hang up and call 000. Step 4. The disclaimer for telephone triage can be, call back if it gets worse. We may need to see you earlier. If this matter is urgent, we will advise you to go straight to your nearest emergency department or to call 000 for an ambulance. Step 5. Informing clinical staff. Step 6. Document activity. Means you need to check the triage policy and procedures at your practice regarding documentation of triage outcomes in addition to clinical notes by the GP or nurse. If your practice doesn't have a triage policy, you may wish to keep a record and notify clinical staff according to triage policy of all emergency cases triaged by reception staff, anyone you are worried about, or anyone likely to call back. Documented triage policies and procedures provide evidence that the practice has a system in place to ensure timely care for patients who need it most. It includes procedural guidelines for administrative and clinical staff, a triage tool, e.g. POPGUN's resource that has been tailored to the types of patients seen at the practice, a well thought out triage process with actions to support patient management by non-clinical staff. Triage training should be available for administrative and clinical staff, included in orientation of new staff, offered at practice meetings, and included in refresher training for professional development purposes. Plans to review the triage system suggest that the practice is taking time to evaluate whether the existing triage system is working well, incorporating feedback from reception staff, and possibly using practice staff meetings to discuss triage issues using case studies. In the development phase of a triage policy at your practice, the practice team needs to consider patient demographics, the skill mix of practice staff, the different types of services offered by the practice, and where the practice is located. The triage policy required at an Aboriginal health service in Whyalla, for example, will be quite different from what is required in the Adelaide Hills or next door to the Port Augusta Hospital. Practices in remote locations may even have an alternate or additional number to call for emergency assistance. Consensus is needed by the practice team regarding roles and responsibilities of each team member involved in patient triage. An existing triage template, such as POPGUN's, can then be customised to suit the needs of the practice team, and the patients seen at the practice. Larger practices may have a triage nurse, so this role needs to be included in the triage policy and procedures. The implementation phase includes a practice meeting to plan implementation, making sure that the laminated triage guides are near each telephone at the practice, ensuring sufficient emergency equipment and that practice staff have access to triage and CPR training, that patient information also includes a sign in the waiting room advising patients to update reception staff if their condition worsens, and most importantly, setting an implementation date for the triage policy to commence. The review phase requires the practice team to review RACGP standards pertaining to triage, set a date to revise the customised triage guide, and ensure orientation of all new staff, including GPs, to the triage policy and procedures and triage tools used at the practice. Reception staff need to know who are your most vulnerable patients. Does the practice have the required mix of skills and equipment, or is the best care at the nearest ED or another practice? Always err on the side of caution with infants and children. Bring them in early. Never dismiss parental concerns and interrupt clinical staff if unsure. Babies and young children can dehydrate very quickly if they have been vomiting or have diarrhea. A previously restless and irritable infant who has become withdrawn and is having fewer wet nappies should be seen without delay. The older population is at higher risk of stroke. The FAST acronym is a good one to keep in mind when making these appointments. F. Has their face drooped? A. Can they lift both arms? S. Is their speech slurred? T. Call 000. Time is critical. Your practice may also see immunopressed people having chemotherapy, pregnant women, and those participating in the obstetric shared care program. For patients with chronic disease, keep in mind multiple chronic conditions. Post-operative patients. Patients with psychological distress have been included in this list because of a recent AIHW report, March 2021, and media reports, January 2021, indicating the likely increase in the number of people with psychological distress phoning the practice to book an appointment. The AIHW reported an increase in the use of mental health services and an increase in psychological distress during 2020. The issue has also highlighted by the media in January 2020, who reported a 70% increase in the number of mental health patients presenting at emergency departments in Australia over the preceding 15-year period. For patients presenting with suspected infectious diseases, including flu, measles or chickenpox, 1. Provide the patient with a surgical mask to be worn before entering the practice and to remain throughout the visit. 2. If the patient has phoned ahead, collect the patient from the car park and escort via a back entrance if possible to a secluded area of the practice. 3. Isolate the patient to an area not in common use and fix a laminated sign to the door advising, "Caution, isolation room, do not enter." In regard to personal protective equipment, PPE, for clinical staff, 1. Surgical masks and gloves is a minimum PPE requirement. 2. Additional protective eyewear is required for the collection of nose and throat swabs and if the patient is vomiting, bleeding or coughing. There are far more clues about a patient's condition when presenting in person compared to calling by phone. Note whether the caller sounds relaxed or irritable and agitated during the call. Listen carefully, allowing the person to state the problem in their own words rather than interrupting with screening questions too early. If the person is known to the practice, do they sound unwell or appear different in some way? When the person presents at the reception desk, are they calmly and quietly responding to your questions, or do they appear to be agitated, aggressive and noisy with jerky physical movements and lots of expletives? Consider body language. Is the patient bent over in pain or walking purposefully to the waiting area? Facial expressions. Is the patient's face contorted with pain, and do they appear sad or angry and confused? Speech. Is the patient chatting happily on arrival or slurring, talking rapidly or incoherent? Can you smell alcohol on their breath? Skin colour. Is the patient's skin pink and dry, or do they appear flushed, pale or sweaty? Behaviour. Is the patient hunched over in pain, gesticulating wildly, or acting in a threatening manner as you ask your screening questions, or are they responding in a calm and orderly way and volunteering relevant information? Does the infant, brought in by a worried mum, appear to be unusually quiet, lethargic or floppy? Communicating with sick people or their carers is often challenging. While it is tempting to interrupt, particularly at peak times, this can be very frustrating for the patient who may be trying to tell you some crucial information, such as, "I had some oysters half an hour ago, my tongue is swollen and I can't breathe properly," or "I have a dull pain in my chest and my skin feels clammy." Some patients are not good historians, while others can go off on tangents that don't appear to be related to the actual problem. Allow the patient some time to tell you why they have called, then try to direct the conversation with a series of direct, closed-ended questions. Screening questions such as, Can you tell me your name, date of birth, address and phone number, and specific questions about the nature, duration, and severity of the problem is a good way to get the call back on track. Use verbal and non-verbal clues from the patient and check in with them from time to time to make sure they understand what you are saying. Protect yourself and others by making sure that your questioning is not inadvertently triggering aggressive behaviour. Reflective listening is a good way of checking in with the patient. Summarising what they are saying to you helps keep the questions on track. However, parroting back minute details to the patient may be irritating or interpreted as patronising behaviour by the patient. Always use a disclaimer when ending triage calls, such as, "Call me back if your pain gets worse and we'll try and fit you in earlier." When responding to angry callers, it's important to speak quietly and calmly, particularly if the caller is shouting or sounds agitated. It may be useful to use the HEAT acronym. Hear them without interrupting, empathise with this situation by acknowledging that they sound upset and possibly worried about what is happening, apologise without admitting fault for what is happening to them and the effect that the delay or miscommunication is having on them, and take action. Tell them what you will try and do about it. I'll let the GP know that you're upset about the long wait and we'll try and fit you in at the first opportunity. Whenever someone calls the practice to book an appointment, it is important for reception staff to ask whether the problem is urgent before putting the call on hold. This may be easy to gauge from the tone of the person's voice or sense of urgency. However, some callers may sound calm despite clearly needing an ambulance. Reception staff need to confirm and record the patient's name, date of birth and phone number and ask whether the patient attends the surgery. Ask the patient to confirm their current address and if that is where they're calling from. It is important if the patient collapses while on the phone and you need to call an ambulance on their behalf. Next, ask the patient to describe the problem. A good way to begin is to ask, "To help me give you the most timely appointment, is it okay to ask you a few questions?" The patient may ask to speak to a nurse or a doctor at this stage. Otherwise, proceed asking some questions such as, "Is this a new or recurrent problem, or is this an existing problem that has become worse? Is the pain sharp or dull? Is the pain constant or does it come and go? Have you had any recent admissions to hospital or any surgery? What were you doing when it started? What makes it worse? What makes it better? Do you feel lightheaded? Do you have any other symptoms? Have you taken anything for pain, for vomiting? Are there just a few spots of blood, say a teaspoonful, or enough to soak a pad? How many pads have you changed in the last hour? Is there any pain with the bleeding?" Ask about the duration of the problem. How long have you had this problem for? Hours? Days? Weeks? To determine the severity of the problem, ask, "Can you tell me how bad your pain is today on a scale of 0 to 10, with 10 being the worst pain you can imagine?" It is important to ask whether the patient has any existing major health problems, e.g., is the caller feeling faint and clammy? Could be an unstable insulin-dependent diabetic who needed to call 000. If the patient can't name the condition, ask what regular medications they are taking and if they have any allergies. If unsure or the problem sounds serious, put the call through to a GP or nurse. Reception staff need to understand the complete set of actions required when triaging patients and their role as non-clinical staff in the triage process. It is not the role of reception staff to diagnose the problem or to provide clinical care. 1. Use a triage tool such as pop guns to categorize the problem into one of the 6 categories from A to F. 2. Follow the actions recommended for each category. These are specific instructions for the patients, such as come to the surgery now. 3. Include a disclaimer at the end, such as come to the surgery now and call back if it gets worse. 4. You will notice that the timing for informing the GP or nurse will vary according to the urgency of the condition and the triage category. For example, call for help now in category A is unequivocal compared to simply informing the GP or nurse about the appointment. 5. Upon receiving the patient's file, the additional steps for patients in category A and category B include informing the emergency department and sending required information to ED staff. This is normally done in consultation with the GP or nurse. Check your practice's triage policy in regard to documentation of triage outcomes. These notes are recorded by the person conducting the patient's triage, in addition to clinical notes recorded in the patient's history by the GP or nurse. Documentation is recommended for emergencies, anyone that you're concerned about, and anyone likely to call back. There are some subtle but important differences between Category A and Category B. Patients in Category A have a condition that is sufficiently life-threatening to require an ambulance and to call for assistance from the GP or nurse immediately. Patients in Category B need to attend the emergency department without delay, and the GP or nurse should be interrupted immediately. It is important to remember that patients assigned to less acute categories can deteriorate upwards to a Category A or B in a matter of minutes. Ending calls with a disclaimer provides the patient with specific instructions about what to do next if their condition worsens. Calls from patients with conditions in Category C should be transferred to the GP or nurse, and clinical staff immediately advised if the patient presents in person. Patients calling with conditions in Category D should be advised to attend the clinic immediately for triage by the practice nurse. These patients can be slotted in between appointments or observed in the waiting room and seen at the end of the session. Although the time frame for informing clinical staff in Category F is less restrictive compared to Category E, that is, inform GP or nurse within 30 minutes, you will notice the disclaimer, call back if it gets worse, at the end of both of the recommended actions for Category E and Category F. Take some time to reflect on some of the triage activities that you are involved in every day at your practice. Here are just a few scenarios that you may be able to relate to. Advising relatives to hang up and call 000, transferring urgent calls to the GP or nurse, leaving some appointment slots free each day for urgent cases, updating patients on waiting times to see the GP, especially if there is an emergency at the practice. This includes letting patients in the waiting room know and calling patients at home to advise a delayed appointment time, arranging a home visit for a patient with flu, or reducing the risk of transmitting a communicable disease by arranging to meet the patient with flu in the car park after donning suitable PPE, providing the patient with a mask and escorting them through the back entrance to a secluded area and putting a sign on the door marked isolation room, do not enter. All emergency calls should end with a disclaimer advising the patient to call back if the problem gets worse and advising the patient of the likely outcome if that was to occur. The key points in the disclaimer in this slide are: your symptoms could become worse or change. If that happens, call back to arrange an earlier appointment. If we find that your situation has deteriorated significantly, we may advise you to either go to your nearest emergency department or hang up and call 000 for an ambulance. So what is the purpose of documentation? Documenting triage outcomes helps to ensure a robust triage system that meets best practice and accreditation standards, is safe for patients and their families to access, and provides staff with medico-legal protection. It is also useful evidence if things go wrong. It is important to document symptoms described by the patient and the triage category assigned, outcomes, specific management advice given to the patient, and informing clinical staff. Whether staff advised the patient to call 000, whether the emergency department was notified, and information sent. Critical documentation includes any deviation from the triage policy and procedures at the practice and why, record in the notes section. Any follow-up instructions or advice given to the patient or carer, whether the patient refused any recommended actions. Next, we will look at the patient triage contact form developed by Country SA PHN, the one which can be tailored to reflect triage policy at your practice. It is recommended that this two-sided PopGums triage process resource is tailored to the needs of the practice, including patient demographics, your location, skill mix of clinical staff and non-clinical staff, and the services provided by the practice, e.g. respiratory clinic, aged care, printing advice, colour, two-sided, A4 size, laminated, preferably, or kept in a transparent plastic sleeve. Location, next to the phone in reception, easily accessible, next to the phone in each consulting room, preferably. When enacting your emergency action plan, on the reverse side of the PopGums tool, try to remain calm and don't panic. The patient, their family, and carers are relying on your ability to keep a cool head. Be aware of and respond to safety needs of the emergency, e.g. if that appears that the patient has been electrocuted, instruct the caller to turn off the power, if safe to do so. Use a non-conductive tool like wood or cardboard if required, and do not automatically touch the patient until safe to do so to avoid electrocution. Assess which patient needs to take priority using the symptoms described to you. Ask as many questions as required to determine the urgency of treatment required, but be guided by the urgency of the situation. That is, if hang up and call 1000 immediately is indicated. Deal with any injury or illness in order of severity. A middle-aged person vomiting all night who is otherwise healthy would be less urgent than a 6-month-old baby who has been vomiting and crying for the last few hours and suddenly goes quiet and hasn't had a wet nappy for hours. Call 000 for ambulance, police or fire service. Injured people sometimes need more than one service. It is important to check the RACGP standards on the website for any updates and to regularly review the triage policy at your practice to ensure it still meets the needs of patients and staff. This might include clinical audits, monitoring and evaluation of triage outcomes, and cause and effect analysis. Feedback from reception staff should be included at regular triage review meetings, providing an opportunity for reception staff to raise any issues around their role and communicate their concerns to clinical staff about challenging triage situations. The triage review meeting allows the whole practice team to have frank and open discussions about specific incidents and near misses. This allows reception staff to contribute ideas for quality improvement initiatives aimed at improving the triage system and the triage processes at the practice. It is prudent for the practice to have effective risk management in place to ensure patient safety and the medico-legal protection for staff who triage patients at the practice. Some effective risk management strategies might include regular triage review meetings with input from reception staff, staff training and the orientation of new staff to ensure that all members of the practice team are A, familiar with the practice's triage policy and procedures, and B, understand their roles and responsibilities within the triage processes, and C, consistently use triage tools and document triage outcomes for emergency patients attending the practice. I will briefly reflect on the model for improvement, which provides a framework for developing, testing, and implementing changes leading to improvement. The model provides an easily understandable scientific method which acts to moderate the impulse to take immediate action with the wisdom of careful study. 1. What are we trying to accomplish? This is the goal. 2. How will we know that a change is an improvement? This is the measure. And 3. What changes can we test that will result in an improvement? This is the idea. The PDSA cycle is shorthand for testing a change by developing a plan to test the change. Plan. Carrying out the test. Do. Observing and learning from the consequences. Study. And determining what modification should be made to the test. Act. Country SA PHN has prepared a PDSA cycle example in relation to the pop guns and the triage contract form. This is in Word format so that you are able to adapt to your practice needs. Going through this webinar and filling out a PDSA cycle contributes as evidence towards your quality improvement activities, aligning with your quarterly PIP QI incentive payment. If you require further training on PDSA cycles or a copy of the pre-filled document, please contact us at support@countrysaphn.com.au. In closing, we hope that this webinar has given you a better understanding of the triage process and the importance of practice guidelines. The triage policy and procedures at your practice need to be regularly reviewed against the RACGP standards and include clearly defined roles and responsibilities for all clinical and non-clinical staff involved. Staff training needs to be prioritised to ensure that all new staff, including GPs, understand the triage process at orientation and that there are ongoing opportunities for staff development. Structured systems such as the pop guns triage process ensure consistent decision making, allowing reception staff to quickly identify patients with urgent needs and prioritise the order in which they are seen. Complying with the RACGP standards in this way equates to effective risk management and provides evidence of safe and effective patient triage to meet accreditation requirements. Thank you for your attention. Please feel free to submit any questions about the triage process, use of the pop guns tool, and documentation of triage outcomes by non-clinical staff to support@countrysaphn.com.au.